Hi, I'm Dr. Mark Berman. I want to thank Bruce and Shannon for inviting me to speak at your webinar. I'm speaking to you from the Cell Surgical Network, and we're going to discuss our network and how we can hopefully grow with you in Australia. I started this network with Dr. Lander, preceded by forming the California Stem Cell Treatment Center. About a year into our center, I started talking at medical meetings, and lo and behold, people wanted to join our group. What group, I wondered, and that's how we formed the Cell Surgical Network. Of course, the thing that we're interested in mostly is the stem cell, although I think the growth factors are probably as important or maybe more important. As you'll see, I think of the stem cell as the envelope, the growth. You know, stem cells are probably the oldest therapy, not the newest. We think about this as new, but before you ever had any medical intervention, you were left to your own devices, your own immune system, and your own stem cells to get better or not. So right now, we're just taking the oldest system and giving large quantities in a simple and safe way. I'd like to give credit to Dr. Hyung Lee. He's actually the Tony Stark or the Iron Man who invented the machinery that we use for our system today. Now, Medicon equipment was invented by Dr. Lee, which he introduced to me in 2008. I used it principally for fat grafting, but I knew I could use it for stem cell treatment, but I had to get somebody to work with me to stay in the scope of practice and feel comfortable about it. Dr. Tom Grogan, an orthopedic surgeon, was highly skeptical and also very conservative, but eventually he agreed to see some of my patients and treat them. And then eventually he sent his patients to me. We did really well with that. It was really impressive, the results we were getting. And then I told my colleague, Dr. Elliot Lander, who convinced me to form the California Stem Cell Treatment Center in the end of 2010. We formed a multi-specialty group. Right off the bat, we knew this was the important thing that we or any of our affiliates should have, and that kept everybody within the scope of practice. We also felt that we needed a safety study. One of the leading criticisms about what we were doing is we didn't know if it was safe. So now you know there's plenty of sources for stem cells. In fact, there's stem cells associated with every organ in the body until we reach a certain point that we use them all up. Most experience has been with bone marrow, but bone marrow, if you're lucky, may get 50,000 cells that you have to culture over several days in the lab. But fat, incredibly, has this huge number of cells. So 25 cc's of condensed fat might give you 10 to 30 million cells in as little as 80 minutes. Now, bone marrow, as I said, it has to be cultured. Fat we can get without a lab, right in the surgical suite. And we know with fat cells we're going to have a whole bunch of stuff. That stromal vascular fraction is loaded with pre-adipocytes, perivascular stem cells, and parasites, which make up your mesenchymal stem cells, basically. There's going to be some macrophage, Treg cells, epithelial cells, and a whole bunch of platelets and growth factors. The cells within your fat, the stem cells, lie dormant. If there's no tissue injury or anything to stimulate them, they're just going to lay there. They respond to inflammation, degeneration, and cell death. And if you eat a lot of fat, you'll respond to that too, and their body will stimulate them to turn into more fat cells and more blood vessels to accommodate all that extra fat. So they have homing properties. So if you add them intravenously, and they will go to the areas where they see tissue damage. And the cells hopefully and usually turn into the needed tissue. How it does that is through messaging. We believe it's the growth factors that are really important. So we refer to these cells as mesenchymal because that's the part of the body they're at. And typically they can turn into bone, cartilage, muscle, nerve, blood vessels, fat, connective tissue, and probably other kinds of cells too. We've seen documentation. My colleague Jackie C. did a whole paper on all the different cells that they've found fat could turn into, or fat stem cells. Frankly, I think the stem cells like an envelope. When you put an address on it, that's where it ends up. However, the envelope's empty until you put something inside of it. And depending upon how you fill it, what kind of growth factor you commit to that envelope, that really determines what it becomes. What makes this system different is that it's so simple. It's a manual system that's sterile and closed, and it's also a surgical system. So there's no laboratory involvement, not even a laminar flow hood. It's really affordable. And it only requires 25 to 50 ml of fat to get a lot of stem cells out of it, versus some of the really well-known companies like Cytori that require over 250 cc's just to prime the pump. Also, this procedure, if you do it the way we instruct you, can be done under strictly local anesthesia, making it very simple, not requiring any hospitalization, sedation, no outpatient surgical time at all. The patient basically is in and out of your office within 2 hours. In fact, basically, you've got a mini liposuction procedure. That whole portion of the procedure can take maybe 10 minutes. Your patient's then dismissed to get coffee or breakfast. Then you produce the cells in a completely closed, sterile surgical system with medical grade collagenase made through Roche Laboratories. All the cells are filtered, so there's no risk of debris or emboli. And then we can actually document our cells with photomicrographs for viability and total count. This is a picture of the time machine. It's basically a centrifuge. It's pretty light now that we took the liposuction machine out of it. You can see we spin the cells for 2800 RPM for 3 minutes. The combination of the centrifuge and the incubator really is what makes up the system of the time machine. And that incubator is a pretty light device too. You can transport these real easily in the back of your car or in your trunk. We harvest the fat using a syringe technique of liposuction. The syringe is really the key. Those pistons that you see are weighted and filtered. They have a plastic center, which is probably the one flaw in the system, in that we screw this device, the Terralock, into the plastic piston, and you have to be careful not to over tighten so you don't strip the threads. But this allows us to pull back on the plunger and provide a negative pressure within the syringe, and therefore perform our liposuction. We have a simple surgical prep. In fact, everything's on a sterile surgical table, and we keep everything covered under sterile surgical towels. The whole procedure usually takes about 80 to 90 minutes. The patients usually go out for coffee or breakfast while you're preparing the cells. We have a safety study with over 1,000 patients and no real significant findings related to SVF. Most of the reactions we've had are all related to liposuction, the typical things, tenderness, bruising, maybe a little localized wound infection. But really, there's been no reports to the CDC. Even VetStem with over 10,000 animals hasn't had any serious injury noted. And one of the interesting things is we have two medical malpractice companies that are willing to give coverage to all of the members of our USA affiliate network. We also now have 8 additional IRB studies dealing with clinical outcomes and safety secondarily. So we have the orthopedic areas of knee, shoulder, hip, and back, urologic areas, erectile dysfunction, interstitial cystitis, and Peyronie's. We have cardiac and COPD and asthma as well. We were really happy to get the approval for the Amaya reservoir. Chris Duma, a leading Southern California neurosurgeon, came up with this idea. We had to do a rat study initially to show it was actually safe, and then we finally got approval for Alzheimer's, Parkinson's, and multiple sclerosis. Now, with a little port under the scalpel, it delivers cells directly into the cerebral spinal fluid. So we already know that stem cells can be used for almost any inflammatory degenerative condition, and especially autoimmune conditions as well. And while cosmetic surgery has its uses, by far therapeutic trumps that many times over. In orthopedics, we've used it on almost every joint. I've put it in digits in China, where I don't have an orthopedic surgeon to work with. But you can see it up and down the spine, ankle, hip, knee, elbow, wrist, shoulder. We've seen some amazing results where people are able to actually open a jar the next day after an injection right into the CMC joint. As you can see from these x-rays, after 4 months, you actually have increased joint space. That's somewhat objective evidence that there's something going on, hopefully cartilage growth. But it correlates clinically. My first patient was our nurse anesthetist who had a crunchy knee from a ski accident and previous arthroscopy, steroid injections, and NSAIDs, but nothing was really helping her. We gave her an SVF treatment. We gave her a follow-up treatment several months later, and she has been skiing again without pain. We have some hip data on our outcome studies showing decreased pain in multiple patients over time. Interestingly, my wife was our second patient. She had 3.5 years of chronic hip pain from being a chronic runner, and after SVF injections, she's now been 3.5 years pain-free. And that was preceded by multiple treatments of NSAIDs and steroid injections, and none of those things helped. We consider the orthopedic area the one of low-hanging fruit. Imagine you can avoid total joint replacement. Your patients can be relatively pain-free without the morbidity and mortality associated with it. And the orthopedic surgeon, in just maybe 20 or 30 seconds, does an injection and probably makes just about as much money as he would with a total joint replacement. So we think this is a great area to be combining services with your orthopedic colleagues. So here we have an MRI with gadolinium. At the area of the bulging disc on the left, you can see on the right side a highlight. That's the area of inflammation and the area where the radiologist will inject. Here we demonstrate a CT-guided injection so the radiologist can put the SVF right on the spot where the inflammation is, as demonstrated by the gadolinium. We've seen some interesting results with Parkinson's. I hope that it gets better using this Ommaya reservoir, but for right now we've had to use intravenous injections. Here we have some objective evidence several months after initially trying to draw concentric circles. We can see that the circles and the lines are a lot smoother, indicating less shakiness following SVF. Myasthenia gravis is pretty interesting. We have one patient who used to go away skiing with her friends up to the point that 4 years ago she could no longer ski, and her friends had to actually assist and walk her up the stairs to the condo where they stayed. After a couple treatments, she was actually able to go skiing, and she's been fully functional for the first time in 4 years. We've seen improvement with multiple sclerosis. In one case, we had somebody who needed assistance in walking, but she could walk. And a week later, she was able to drive herself to the clinic and walk unassisted. On the other hand, we have somebody in a wheelchair who's had several treatments, and she could just barely get out of the wheelchair now and walk with a walker device, which is not very good, but it's a little bit of improvement, which shows you that these diseases are so variable. Not only is SVF variable, the degree of your disease is variable. I often tell people with these neurologic conditions, kind of like they have a fire. We don't know if it's a little fire that you can put out with a cup of water, or we're going to have to throw a lot of water at it many times before we can, slow it down and reverse the process. We've seen improvement with muscular dystrophy, CIDP, cerebral palsy. These people actually talk about how they get bowel and bladder function back, which is really important. They get improved strength. There's an overall fog that goes away. With cerebral palsy, we were really surprised to see improvement in coordination and even significant weight gain, which allowed improved coordination. One of the most interesting cases I had was a patient with blindness. She could see white light on 40 milligrams of prednisone because she had optic neuritis. We scheduled treatments. After a couple treatments, she actually started getting better and decreasing her prednisone levels significantly. I've treated her nearly monthly for 2 years now, and she's off prednisone altogether. In fact, she even passed her driver's test she could see that well. So it's been a real exciting thing to be able to combine my cosmetic tools and then work. And when you get something like this, a little Christmas card saying, "Thank you for giving my mom a second chance. Now she can watch me, grow up, drive, graduate, play sports." I mean, it's really heartwarming. I started to mention there's some diseases that you're told are untreatable. Well, COPD definitely is one of those. And yet we have patients who are basically been given a death sentence, and within a month or two later, following SVF treatment, they're walking around without their oxygen. And this stuff is just really exciting to see. And these people tell their friends with COPD, and they come in as well. We had a patient on a transplant list for a new heart. He was just in really bad shape and had a lot of trouble just even ambulating. Um, he felt kind of weird for a few days, turned a little bit green, and seemed strange, but by the end of a few weeks, he was able to exercise. He said he was out in the yard doing ranch work, splitting wood, and he was back having a great sex life, things that he couldn't do at all. And consequently, they took him off the transplant list. His ejection fractures were considerably better, as you would expect. My partner, Dr. Lander's done a lot of great work with urologic conditions. Erectile dysfunction started out difficult to fix until he started adding ultrasound, which seemed to break up or irritate or cause some micro damage to the vascular structure. And this was a signal that was necessary for the SVF to enhance the blood flow in that area. Peyronie's seems to work pretty well. And he's had some really good results with interstitial cystitis, which is almost impossible disease to live with or to treat. Um, he's also done some cases where patients have come in with renal insufficiency. So when you get improvement in your kidney function, that's kind of a neat sign that these cells are more than mesenchymal. So what's our success? Well, right now we have to be careful about making claims. We're amassing data. We'll have a lot of outcomes that we can look at. We'll have obviously anecdotal and testimonial information, but I think the important thing are these early clinical trials and results that support what we're doing. So as we amass this clinical outcomes, eventually we'll be able to do some more evidence-based studies. I think once you identify trends, then it's okay to do this empirical work and then progress to more evidence-based studies to prove why it works. Seems like all the work's been going backwards. Everybody wants evidence-based studies, but sometimes you can do those and not get the result you want, and you can get confused. So there's nothing wrong with doing empirical testing. That's the way medicine has advanced all along. And if you don't get the right results, you move on and you look for another source, or you drop it until somebody else finds something better. And don't forget what I said earlier. We've had multiple failed placebos, so when you get a good result with SVF, it's quite unlikely that it's because of a placebo effect. So the key to the cell surgical network is we can put a lot of groups together, share our equipment, protocols, and techniques, and particularly the online database and patient registry. We'll be able to stratify all this documentation, and we basically provide you the IRB protocols. You're welcome to add your own protocols that we can help you get approved or help you write or perfect. We are all working with multidisciplinary team. This improves the quality of care and keeps us all within the scope of practice. And as we move forward, we can advance our deployment techniques. Right now, everything's autologous, but in some cases, we might look at allogenic therapy as well. We'll see how the whole industry, if you will, moves forward. I kind of believe that in a few years, we'll have enough data to possibly put ourselves out of. So, as I mentioned, you can go to stemcellrevolution.com. All this information is on that site. we certainly can grow the site and you can be part of it and help it grow as well. And just in case I have any friends out there who are Ayn Rand aficionados who've read The Fountainhead or Atlas Shrugged, you can actually type in who is John Galt stemcells.com, and I might be infringing on somebody's trademark, I suppose, but if you've read those books, you'll know where we come from. It's interesting that the group we're working with are forward-thinking people. They're not trapped in the box. They're not afraid to kind of take a risk. But we're not really risk takers. We're doing a really simple, as I said, old intervention. And there's plenty of research to support the safety. As I mentioned before, that there hasn't been a single incident reported to the Center for Disease Control in the United States. So there really haven't been any real problems. We've never had any problems with the Medical Board of California, and none of my colleagues have had any problems that I know of, and certainly no lawsuits have been filed so far. Our patients are happy with their treatment, particularly since we advise them with a well documented informed consent right from the start that they might not get better. That doesn't mean it won't work. Sometimes we recommend bringing them back at a lower cost and treating them again. But for right now, all I can say is this has been a lot of fun to be able to present this to you. It's truly been the most amazing part of my medical career, and I just wanted to end the last slide without cutting out. It's really funny, but it may have been easier if I just got up at 2:30 in the morning and did this in a half hour instead of going over each one of these slides and making sure I had enough narration. This PowerPoint presentation is not as easy as I thought it would be. Anyway, I just wanted to end by thanking you all for putting this together, Bruce and Shannon, and for everybody who joined me. Perhaps I'll meet you in Bangkok or in Australia in the near future. And I just want to let you know this really is an amazing experience. Hopefully it will be for you as much as it has been for me. So thank you once again.